If you haven't done so already, and I know you haven't because nobody has, could you please go ahead and share your name, affiliation, title, and email in the chat? I'm also going to invite everyone right now to mute themselves. And please don't take it personally if I mute you during the call. You can unmute during questions. Enter any questions you have throughout the presentations into the chat, and we'll address them at the end of the presentations. We will be recording this session and emailing it out to attendees later. If you are on the phone and would like the session emailed to you, my email is efield, that's EFIELD at usetinc.org. You can shoot me an email and I'll make sure you get the recording. And towards the end of the session, I will be sharing an evaluation link in the chat. It's just a couple questions and we're just looking to get some feedback and figure out how we can make these more useful for you. And we have started recording. All right, that's all.
Okay, great. We can go ahead and get started with the Epicenter updates with Christy Duke. So, Christy, we're waiting on the presentation. Actually, I have the presentation up.
Good afternoon, everybody. This presentation is going to be pretty brief. I'm just going to go over the latest testing numbers from the past week to see how much we're testing and how many positives that we're seeing in the Nashville area. Christina Rogers at the Nashville area office and the USET staff have been working very closely together with collecting this data and sharing this data. So we appreciate that. As we know, getting the information from RPMS can sometimes be taxing. So right now we've got 27 sites reporting. I believe last week there were 26. And so far, this past week, we have 3,465 tests being performed, and that's up from 2,798 this time last week. There were 312 positives, up from 224 from last week. And just a note on the positives, these may not be the same as the number of cases. We are hearing some reports that tribes are testing more than once. We are trying to look at ways to get accurate case numbers, but it's been difficult doing that. So 312 positive tests. And there have been 2,873 negatives, and that's up from 2,277 this time last week. So that's where we are in terms of testing. It does seem like sites are testing more, and we're glad to see that. I know with the rollout of the Abbott analyzers, there was a little bit of a learning curve with those and the false negative rates and the new recommendations from Abbott about using transport media or not using transport media and how that affects the results. So, but we are seeing more testing and we are seeing an increase in the number of positives, but it's not a real dramatic increase at this point in time. So we're glad to see that. We've heard that there are obviously some tribes that are affected more than others. If you are in one of those tribes or you are concerned that you might be getting affected soon, please reach out to us to see if we can provide you with any assistance. You can go ahead and flip, Brian. These are the questions that I asked you last week, and I actually received an email from somebody later on answering these questions. So if you have any thoughts around this, please share them with me or with any of the EPI staff, because we really want to hear from you about how we can best serve you. We do have some things that we're rolling out. Cherokee shared their contact tracing guide with us, and we are going to adapt it and send that out for people to utilize. We have more recommendations for tribal consideration coming out. Dr. Brown is working on like a quick testing guide that compares and contrasts all the different tests that are out there. We're going to have kind of two versions of that. One is going to be more complex and scientific, and then another easier to read, just at a glance summary. So those are coming up soon. As always, don't hesitate to contact us. Should you need anything, you can go ahead and flip, Brian. And this is our contact information. We all have our individual emails, which most of you have, but I'm asking you to use the usetepi@usetinc.org email address because that emails the whole team. And so if somebody is unavailable or out of the office, somebody else is getting that message. So please let us know if you need anything else. And I believe Dr. Brown is going next, correct? Or Dr. Mira?
Dr. Mira is going next.
Dr. Mira. So I will turn it over to Dr. Mira. Thank you.
Thank you, Christy. And I have a question for you, but I think I'll give it after my presentation so my question is more clear.
Okay.
Let me share my screen. Okay. So I just want to mention, I don't have any slides on or information, detailed information on treatment. I think there hasn't been major breakthroughs on treatment yet. The only thing I want to mention is that the more studies that come out of hydroxychloroquine, the more we are deterred from using it because there's really no evidence that it works, or there's some evidence that it could be harmful. And we're still waiting for more remdesivir information and convalescent plasma and anti-inflammatory agents for the cytokine storm that seems to happen 2 weeks down the road, 2 or 3 weeks down the road in these patients. When I have more significant data, I'll present that. Just, the CDC it has been a little bit confusing with recommendations for screening lately. I mean, confusing because they change it very often. And so we put it out to all our providers, and then the next day it changed, and I have to go and change them again. But this is the last one. I think it's a reasonable one. So anybody who shows up with a cough, shortness of breath, or difficulty breathing, fever, chills, muscle pain, headache, sore throat, or new loss of taste or smell should be considered to be COVID positive until proven otherwise. And this is the Cherokee Nation, this is the questions that the screeners at the door ask everybody that's coming in the facility, healthcare providers or patients. And if they are positive for any of these symptoms, then they're evaluated by a nurse just to make sure that someone may say, yeah, I have a headache, and then you find out they have migraines and it's your chronic migraines and they haven't changed. So we will not screen that patient. But or someone with fibromyalgia can come in and say, yeah, I have muscle pain because they have it every day, poor souls. But we want to make sure that we're trying to screen people who actively have an acute onset of these symptoms. So I want to share this study with you, two studies that I think were very interesting. And I know that it's cluttered with a lot of information, but there is a graph that I'll be referring to, and I'll make it simple. So there was a recent review in JAMA about interpretation of diagnostic tests, viral PCR and also serology. And I would like to share with you what they summarized. So the first statement is that most individuals with COVID-19, the nasopharyngeal viral RNA becomes detectable as early as day 1 of the symptoms and peaks within the first week of symptoms. And this can be positive for even up to 4 or 5 weeks. Usually by week 3, it's gone. but some patients will have nasopharyngeal swab detected at week 6. And patient with severe infections may have higher viral loads and higher shedding, but this does not mean that the virus is viable. And this brings us to the second statement, in which the German study that was based on 9 patients, very elegantly done and published in Nature, these researchers found that after day 8, none of their 9 patients was shedding live virus. The PCRs were positive longer than that, but no contagious virus was found after day 8. And this is basically the study that the CDC bases its symptom-based strategy recommendations, that after 10 days from day 1 of symptom, you can stop isolation on a COVID-positive patient. So let me go back, let me go to the chart now so these 2 points are a little bit more clear. So this dashed black line is when symptoms start. And as you can see, either many of the PCRs, excuse me, in different samples, nasopharyngeal, bronchoalveolar, and even stool can be positive before the patient starts being symptomatic, up to a week before. But if you follow the red line is actually infectious virus. So infectious virus, based on that, excuse me, German study, is only detected until day 8. So right barely after the first week, this part here. But you can have a nasopharyngeal PCRs positive even, this is the blue line, up to week 6. I'm sorry. So the other point is that stool has been shown to be positive for the virus by PCR up to 57% of patients, and the stool test can be prolonged for a while. There's controversy if there is oral fecal transmission. There's been one report that they alluded that could have been happening, and we don't have enough data on this yet. There's also different sensitivities of PCR depending on the sample. In this particular study, 93% of the bronchoalveolar lavage or sputum samples were positive. BAL were positive, sputum 72%, nasal swab 63%, and oropharyngeal 32%. Seems pretty low. But the reviewer of all these studies says that false negative results may have occurred because of an appropriate timing of sample collection in relation to when the illness started, and also on the sampling technique, and I think this is very important. But specificity of the test, it's 100%. I mean, you can have a false positive, but that's usually a lab error. A reagent got contaminated, or the technique is not right, because the primers they use for this PCR are specific for COVID-2. So they will not amplify genetic material from any other COVID virus. So going back to this slide, this is the stool, the yellow curve. It can be positive for quite a bit of time. And you can see that bronchoalveolar lavage, which is this one purple one here, tends to stay positive for a longer time than the nasopharyngeal swab, which is the blue one. This is important to know clinically, because if you had we are admitting patients that started with symptoms 2 or 3 weeks ago, and they may have a nasopharyngeal test that could be negative. But if they're coughing, it's probably better to get a sputum PCR than a nasopharyngeal PCR. So just to have those things in mind. So regarding serology, they mentioned what we all know, that when would this be useful? Maybe for patients who present late 2 weeks after the illness has started, the serology test should be positive. It may help in diagnosis because that's when the PCR starts to decrease. It'll help understand the infection in the community and hopefully to identify people who are immune, but we're not really there yet with most of these premises. Let me show this is the purple dashed line is the IgM antibody, and the green line is the IgG antibody. And during the first week, the majority are undetectable or detectable at very low levels. But at second week, 30 or 40% are detectable. And then they peak in the third, and the fourth week is the best week to detect antibodies. And the IgM usually lasts for 7 to 8 weeks, and the IgG lasts longer, but we don't know how much that longer is because this virus hasn't been around that long for us to determine this. But what we still don't know is if these are neutralizing antibodies or not. So the other thing they mention is that when you're choosing a test that, an antibody that is against the nucleocapsid, which is the most abundant antigen, would be the most sensitive. So if you have to choose a test because you want to do this, not that I'm recommending you to do it, look for antibodies that go against the nucleocapsid for sensitivity. For specificity, it's the antibody against the receptor binding domain of the S protein. That's a more specific antibody. And they also claim that point of care testing, although it's widely available, most of the manufacturers do not reveal the nature of the antigens, and it's only a qualitative test, it's not quantitative. So, it's not really recommended to go this route, right now at least. And the presence of neutralizing antibodies can only be confirmed by a plaque reduction neutralization assay, which is very few labs do this, more on a research basis. And there is some indications that high titers of IgG detected by ELISA may correlate with the neutralizing antibodies, but this is not set in stone yet. So just interesting, and hopefully it will be true, but we don't know if it's true or not. And we don't know the long persistence of neutralizing antibodies in these patients, and how long they would be protected, if they are at all. Okay, switching gears. The next are two studies that I think were very interesting because they look at the associations of stay-at-home order and face masking, which was recommended by the CDC. This is public face masking, correlating it with new cases of COVID and also deaths due to laboratory confirmed COVID in the United States. So basically what they try to do is, the US, as many other countries, that implemented stay-at-home orders and face masking. How is this working? Is there any evidence that this works at all? And this is what they try to show. They looked at in the US residents that were affected by these two measures. And the main outcomes were, what were the turning points of daily new cases and the turning points of deaths, of daily deaths, and also when did the reproduction numbers change. So the RT is similar to the R naught, but not exactly the same thing. The R naught is how many one infected persons infects, considering that the whole population is not immune or susceptible. And the RT does not take it does take into account the people who may be immune or not susceptible. But anyways, this is what they did. So this graph shows the percentage of people in the United States of total population that were affected by the stay-at-home orders. And when the epidemic started, or the pandemic started on March 19, less than 10% of the US population was under those orders. California was the first state to implement this. And then as time went by, hitting the end mid-April, almost 80% of the US population was under that stay-at-home orders. So I'll walk you through these graphs. This first line, one with the circles, open circles, is the actual number of US daily cases in the United States. And you can see in mid-February, it starts increasing. And March 23, you see that the steepness of the slope changes. It is increasing, but at a slower pace. This is when the stay-at-home orders were maximally implemented, at least 10 states. And April 3rd is when the CDC recommendation to use face masks was implemented, and also this tends to plateau there. This is what really happened. And these are models that these authors did to see what would have happened if these orders had been implemented 21 days before they were actually implemented, 14, 7, and 4 days before. And as you can see, the impact in their model would have been much more important on the number of cases. And this is the same graph, same number of cases per day, the real deal. And then this is when we stop. I'm sorry. These are the different scenarios. What happens if we stop the stay-at-home orders completely? And this is the result with their model is how the cases would increase with these green triangles. And if we continue what we're doing is the purple, and different scenarios of you stay at home orders are reduced by 75, 50%, or 25%, what would the different scenarios be? But except for you keep on doing the same thing, the new cases will increase according to their model. So they did the same thing with death, daily deaths. So this is the real deal of the people who died, unfortunately. April 3rd is when the CDC implemented the mask thing. And here are the models of what would have happened if we had implemented these orders 21, 14, 7, and 4 days before we actually did. And on the right, similar situation, but instead of daily cases, this is daily deaths. What happens if, when the study ended for these authors was, I think, April 17 or 18, if we stop the home isolate, the stay-at-home orders, this is what the green triangles, this is how deaths would increase, and the different scenarios on how aggressively you discontinue the stay-at-home orders. So then finally, the RT, which is the rate of transmission, the yellow line is when California implemented the stay-at-home orders. The green dashed line is when 10 other states did it, and the blue line is when the CDC face mask recommendation was given. And you see that the rate of transmission started to decrease, and then it plateaued here a little bit, and then it started to decrease again. And remember that the RT above 1, that means that transmission is still ongoing, and below 1 is that there's no transmission, so we're in the safe zone. So this is the impact of the different measures on the transmission rate. And actually, this is the number, if measurable, and that's the question I had for Christy. If measurable, this is probably the best number that you have to use to see when you implement or take away interventions like stay-at-home orders. Because if it's below 1, you're safe. It's above 1, you're not. Now, how difficult it is to measure this number or how precise, that's a different story. So these authors conclude that the two turning points of COVID-19 daily new cases or deaths in the US were associated or appear to be associated with the implementation of stay-at-home orders and the CDC's face masking recommendation. That simulation on early implementation and removal of these orders had an impact on COVID-19 daily new cases and deaths. And these findings may inform decision-making on lifting the stay-at-home orders or the face mask use. The other study that I'll walk you through briefly is they measured, also done in the United States pandemic, measured the impact on non-pharmaceutical interventions and the rate of transmission and some other COVID-19 variables. And basically what they did to normalize all the states, they started measuring the impact after each state reached 500 cases. And what they measured was what was the transmission rate between after they reached 500 cases, and what was the doubling time? How long did each state take to go from 500 to 1,000 cases, depending if they had implemented the stay-at-home orders or not. And they adjusted this for population density, GDP, and other metrics. And they also did the same analysis for deaths and instead of cases. But for deaths, instead of 500 to 1,000, they did from 50 to 100. So the results, and I'll show you a graph, but the results states that stay-at-home orders in place at the time of their 500th case were associated with a lower average rate of transmission for the following week compared to those states that did not implement these stay-at-home orders when they reached 500 cases. And this was statistically significant. Also, the doubling time was longer, from 500 to 1,000 cases in those states that implemented those interventions. And they also looked at states in which had implemented the intervention, but they measured actually how many people stayed at home versus how many did not stay at home, using the highest quartile of average time spent at home compared to the lower quartile. And that was also statistically significant, meaning a state can have the order to stay at home, but not everybody will comply to it. That's variable, depending on actually how you enforce it or how strongly you recommend it. And they measured this through the Google report of using cell phone data of how many people have actually, I mean, not the people, but their cell phones. I always say if it was my wife, she would always be at home because she forgets her cell phone. But I assume that not everybody is like my wife. And she's not listening, that's why I can say that. So the conclusion was states with stay-at-home orders have 93% decrease in the odds of having a positive rate of transmission. And states that plan to scale back such measures should carefully monitor these transition metrics. So this is the graph that shows this. The light blue columns are states that did not implement stay-at-home orders before they reached their 500 case. And the dark blue ones are the ones who did. Being on the right is better than being on the left, because that means your rate of transmission is lower. Here, there's the rate of transmission of 1. I should have put a line here. We put a line across here. Oops. The more states that do it tend to have a lower transmission rate. And this is just from another website showing you, this is COVID Act Now. The states that are in red, that means that they have high transmission rates. The ones who are in yellow have moderate, I mean, they're above 1, but not as high as the red ones. And the ones that are in green are below 1, which is Montana, Vermont, Alaska, and Hawaii. And what is worrisome to me, if this data is correct, assuming that this is correct, that we're starting with relaxing on the stay-at-home order measures in most states, and actually only a few of them could actually do it by epidemiological evidence. And this is another website called endcoronavirus.org, in which Stanford University is one of the associates. And this shows each country, and I just took a snapshot of some of the countries. US is not the only one that's on the red. There's about 20 countries on the red, but this is more similar. This is the curve of each country. And many countries are in green, many are in yellow, but we are still in red. As you can see, the number of cases, our curve has really not decreased. It's still plateauing, and this was done until May 5th. So this could have changed a little bit. Okay, I will skip this one for time reasons, and I will stop there. Thank you.
Thank you, Dr. Mera. Next, we'll move on to Dr. Brown. Tilo, if you'll load his presentation.
Good morning, everyone, or good afternoon, wherever you happen to be. And thanks for the opportunity to talk to you today. I'm going to be talking about a couple of different things. I'll spend most time talking about Kawasaki disease, just reviewing Kawasaki disease in general, but also talking about this new relationship that's been discovered with COVID-19. And then at the end, I'm going to totally go away from this and talk about a new test that's out, an antigen test, that I won't spend a whole lot of time on. Next slide, please. Yeah, so this is what I'm going to cover. Go ahead. So the man on the left there is Dr. Tomosaku Kawasaki, and he was the physician that first noticed these cases in children of a strange disease, and he described this mucocutaneous lymph node syndrome in a Japanese medical journal in 1967. The first article that was published in English was published in Pediatrics in 1974. The first cases described really outside of Japan were in 1976 in Hawaii. So Kawasaki disease, and now it's pretty much known as Kawasaki disease rather than mucocutaneous lymph node syndrome. I think it's just a little easier to say Kawasaki disease. And by the way, Dr. Kawasaki is still alive. He's 95 years old and still involved in research, which I think is just wonderful. But this is one of the most common types of vasculitis in children. It's a systemic inflammatory response that affects medium-sized arteries, and in particular, it affects the coronary arteries in the heart. Next slide, please. So just looking at the epidemiology, this is a disease almost exclusively of childhood and early childhood at that. 80 or 90% of cases occur in children under the age of 5. It's uncommon to see it before 6 months, and it does occur in kids over the age of 5, but they're a minority of cases. It's extremely rare to see it in adults. There are only maybe 100 cases reported in the worldwide literature. It is more common in people of Asian descent. In the United States, it's much more common in people of Asian or South Pacific island descent. It's about medium in Hispanic and African Americans, and it's least prevalent in white people. I couldn't find anything specifically about American Indians, but I would postulate that it's probably a little more common just because they're more genetically related to people of Asian descent. In the US, there's a winter-spring predominance, whereas in Japan, it's most prevalent during the winter, and then they have a second smaller peak of cases in the summer months. Another interesting fact, they found that in Japan, if one child in a family has it, the siblings of that child are at a 10-fold increased risk of having Kawasaki disease. If you have a parent who previously had it, you have a 2-fold increased risk. So it's postulated that there's a genetic predisposition with probably an infectious trigger, but no definite single causal agent has been found to date. Next slide, please. So the disease itself, there's usually a prodrome that's about a week to 10 days before the onset. Usually GI or respiratory symptoms are the most common, or a combination of the two. The GI symptoms are usually diarrhea, vomiting, abdominal pain. The respiratory symptoms are usually cough or runny nose. Most kids that get this show some irritability, decreased appetite, and they're just puny for a few days before the onset of the classic symptoms come out. Some children have joint pain associated either before the outbreak of the actual disease or as part of the disease itself. Next slide. So the clinical features of Kawasaki disease, if you don't have fever, it's very difficult to say that you have Kawasaki disease. Fever occurs in virtually 100% of the cases, and it lasts a long time. Typically, it's 5 days or more, and it's usually over 38.5 degrees centigrade, which is 101.3 Fahrenheit. And it is unusually resistant to antipyretics. So giving Tylenol, ibuprofen doesn't usually bring the fever down a whole lot. Then there are 5 what are considered the sort of cardinal signs of Kawasaki disease. Conjunctivitis that is non-exudative. In other words, you don't see a purulent discharge from the eye. The oral mucositis can take the form of red, cracked lips, strawberry tongue. Usually don't see any discrete like vesicular lesions or pharyngitis. The rash can take many forms. It's often a macular rash. sometimes morbilliform. Occasionally there's sort of target-like lesions. There's also a few instances where it seems to provoke a psoriatic or psoriasis type rash in kids that have underlying psoriasis. The rash can be very variable. Sometimes it's extensive, sometimes not. Then there are changes, usually in the peripheral extremities, either the hands or the feet. There's erythema of the soles and the palms of the hand. You often will see swelling of the back of the hand or the top of the foot. And then there's this really peculiar thing that happens usually a week or so, maybe 2 weeks into the disease, where the skin starts to peel off, usually starts around the fingers and toes, and then will be seen traveling up the fingers and toes. Then the fifth sort of cardinal sign that's actually the least common is lymphadenopathy. And this is usually cervical lymphadenopathy. In fact, it's usually confined to the neck, anterior cervical lymphadenopathy. Then there are the cardiac problems that occur as a complication or actually as a clinical sign too. Almost all of these children will have some evidence of myocarditis, and about 10 to 20% will develop coronary artery aneurysms. But this is not actually a diagnostic feature, and we'll get to that a little bit later. Next slide, please. So this is the conjunctivitis that you see in Kawasaki. It typically spares the white right around the cornea, but it can be pretty profound. Next. Next slide, please. This is that very bright red lips. No, this child doesn't have on lipstick. This is just a manifestation of the disease. Next slide, please. Here you see the swelling that kids get kind of on the back of the hand or top of the foot. Next slide. And here's the typical desquamation or peeling skin that they get on the hands and the feet. Next slide. The rash is not always, or probably not usually, this extensive, but it can look like this. It's present in up to 90% of cases. As I said before, it can be macular, morbilliform, target-like lesions, or psoriaform. Next slide. This is just a picture of what one of the aneurysms in the coronary artery would look like if a child's taken and has a cardiac cath. The aneurysm is that big round blob, white blob there in the middle. Next, please. So there are a number of laboratory abnormalities. These are not necessarily diagnostic of Kawasaki, but they do help sometimes with the diagnosis, and they're usually fairly typical. The erythrocyte sedimentation rate, the C-reactive protein will be elevated. Ferritin is typically elevated. The white blood cell count typically is elevated at the beginning of the disease, and it's mostly a leukocytosis with a paucity of lymphocytes. There's a reactive thrombocytosis. In other words, the platelet count goes up, sometimes as high as 1 million. Anemia, which is usually normocytic and normochromic, occurs in many cases. The transaminases or hepatic enzymes may be elevated. There's a sterile pyuria that occurs. In other words, white blood cells in the urine. Now, this is a little bit interesting. These are not typically leukocytes, so they don't cause the leukocyte esterase test on a dipstick to be positive. And they're also usually from the distal urethra. So if you do a suprapubic tap or a cath specimen, you may not pick this up. So it's important just to have the child urinate into a cup and do a microscopic exam. Hyponatremia, when it occurs, is usually a sort of bad prognostic sign. It has a higher association with the coronary artery aneurysms. Every child with Kawasaki should have an echocardiogram or probably a series of echocardiograms to look at both cardiac function and also to look for these coronary artery aneurysms. Some children will wind up needing catheterization, but this is fairly uncommon. Next slide, please. So the diagnosis of Kawasaki's has not really changed since Dr. Kawasaki developed the criteria. So the criteria basically for classic Kawasaki disease is fever for at least 5 days plus 4 out of 5 of those cardinal signs, either the conjunctivitis, the oral mucositis, those changes that you see in the hands and feet, a rash, or cervical lymphadenopathy. If someone only has 2 of the 5 or 3 of the 5, they may have what's called incomplete or atypical Kawasaki disease. That can be very important because these kids that have the atypical Kawasaki disease can still develop the cardiac problems. So in cases where you suspect it, but they don't quite meet the criteria, sometimes that combination of lab findings can be really helpful. And it's important to go ahead and work these kids up with echocardiograms. Next, please. So there are a lot of things that can mimic Kawasaki disease, and you have to be very careful in making the diagnosis that you're not misdiagnosing it. Several viral diseases, some of the group A strep manifestations like toxic shock syndrome or scarlet fever. The rash of Rocky Mountain spotted fever can fool you. Leptospirosis, Stevens-Johnson syndrome, serum sickness, and then systemic juvenile idiopathic arthritis that used to be called juvenile rheumatoid arthritis can also mimic some of the findings both physically and laboratory-wise of Kawasaki. Next, please. So the complications, I've already mentioned that there are cardiac complications. Most of these children, if not all, will have some myocarditis present. Many also have pericarditis. You may see pericardial effusions. These are usually small and don't really cause a problem, but sometimes you can actually pick that up on physical exam with muffled heart sounds. And then the coronary artery aneurysms are the sort of feared complications. And this is what needs to be followed with an echocardiogram. There are 2 rather severe forms of Kawasaki disease. One is Kawasaki disease shock syndrome, and the other is macrophage activation syndrome. Kawasaki disease, the vasculitis is characterized by macrophage infiltration, which is not found in any other vasculitis among children. But there is a syndrome where the macrophages become overactivated and you end up with cytokine storms and that sort of thing. Next slide, please. So the treatment is fairly straightforward. It's been found that intravenous immune globulin drastically cuts down on the cardiac complications, and it should be given at the right time in the disease, not too early and not too late. Aspirin is pretty much universally used, although there's not as much evidence to support its efficacy. And then steroids are used in some cases, usually ones that don't respond to the IVIG, or in cases of the Kawasaki disease shock syndrome or the macrophage activation syndrome, steroids can be very useful. Next, please. So let's talk now. This is what you all came to hear about this morning. And that's these clusters of children that have presented in association with the COVID-19 pandemic that have this multi-system inflammatory syndrome that often looks like Kawasaki disease. So there have been 3 sort of clusters, case reports, although anecdotally, there are a lot more of these in Europe and probably elsewhere. So 3 of these have been reported in the literature. In Italy, in the Bergamo province, where they had the most number of cases. They noticed in the main pediatric hospital there, there were 10 children in 2 months with Kawasaki-like disease. This is 30 times what they normally see in terms of Kawasaki. Likewise, in London, there was a cluster of 8 children with hyperinflammatory shock and features of Kawasaki disease during a couple of week period during April. New York City, there was a series of 15 children, either with typical Kawasaki disease or incomplete Kawasaki disease, or a toxic shock sort of picture between April 17th and May 1st. Next slide, please. These are, there's some interesting features of this. These kids tend to be older than the average Kawasaki disease. As I said early on, you usually see Kawasaki disease in kids under 5. A lot of these children have been older. There's been a predominance of boys, but that's true also with Kawasaki, classic Kawasaki disease. And interestingly enough, most were PCR negative. But when they tested them for antibodies, most were positive. And I think this is just a reflection of where they are in the disease. You saw the graph that Dr. Mira showed a little bit earlier. The detectable RNA is waning after the first week or 2, and then the serology becomes positive. And this is probably a reflection of these kids come into contact with COVID-19, they become infected, don't really get sick with typical COVID disease, and then later they develop this Kawasaki-like disease. If they meet Kawasaki criteria, they should receive IVIG. If they have the shock syndrome, steroids are definitely indicated. And the Italian group, at least, they used steroids in, I think, 8 of the 10 kids they had, and had no adverse outcomes from that. So I think the feeling is that it's safe to use steroids in these situations, whereas normally you don't use them in COVID-19. Next slide, please. So I'm going to shift gears here and just speak very briefly about the first antigen test that was released. So 2 weeks ago, I did a presentation that was about testing in general, and one of the things I said was that these antigen tests would be coming out, and sure enough, the first one came out a week ago. Came out last Friday. It is a CLIA wave test, can be used at the point of care. It's a so-called lateral flow immunofluorescent assay. It does require the Sophia 2 machine, which costs about $4,800. And it actually tests for the SARS CoV-2 nucleocapsid protein. It's not the RNA. This is not an RNA test. It's actually a protein test. It's quite similar to the rapid flu tests that some of you are probably familiar with. The results come out in about 15 minutes. So that's all the good stuff about it. Let's look at the sensitivity and specificity. So the performance was based on 2 studies. They compared it to PCR. Both studies gave about the same sensitivity and specificity. It was a very good test in terms of specificity. They didn't have any false positives, but not so good in terms of sensitivity. It missed about 1 in 5 of the positive PCR cases. They did test it extensively for cross-reactivity to the other 4 human coronaviruses that are common to infect people. And out of 79 samples tested, there were no positives, so they feel like that this has a very low cross-reactivity. So I guess the bottom line is, are there any advantages to this test? Well, it could be used as a point-of-care test. If you get a positive result, I think you can feel pretty confident that it's positive, but a negative test result in the case of somebody who's got typical symptoms, should not be interpreted as negative, and you should follow that up with a PCR test. That's assuming that you have the $5,000 machine that it takes to do this test. So I probably wouldn't advocate that any of you run out and buy the Sophia 2 machine just to do this test, as the sensitivity is not that great. So I think that's about all I had to talk about this morning.
Okay,
Thanks very
great.
much.
Yeah, thank you. Do we have any questions for either Dr. Brown, Dr. Mara, or Christy?
I have two questions, and I have to leave in 5 minutes. So if I can, one is for Harry. I don't know if you mentioned that. Maybe I missed it. The cost of this antigen test. If you have any idea on what that's going to be.
Yeah, I'm not sure. I couldn't find the exact cost. I did see something in it was not a scientific journal or anything. It said the cost was probably about $40 or $50 a test. That's excluding the machine that you have to read the test, which is typically around $5,000.
Okay, thank you, Harry. And Christy, my question was how easy it is to measure that RT in your population, because if from what I've read, and I'm not an epidemiologist, but from what I've read, that would be the best number to use for deciding when, to measure the activity of the virus in your community and to see when you need to shut down or open up or whatever you're doing.
She may not be.
Oh, okay. Well, if she can, I'll email it to her.
Okay.
So we have a few minutes. So, I'm looking at this antigen test, and we're always wanting cheaper, faster, good tests. But if the cost is that high, because it's very similar to the cost of like an Abbott PCR or the Cepheid PCR, it might just be faster. I mean, you get and you can do it on a point of care. That's the advantage. But if you have a positive bingo, you can deal with that result and you're done. If you have a negative, you may want to reflex it to a PCR, especially if you think if you're suspicious. But maybe for asymptomatic testing, it would be fine. Even if you lose 20%, but you're still picking up 80% of the ones who are there, it might be more feasible to do, to implement. So I think that was a great presentation, and I think it's something to consider down the road when we have more information. And also, thank you for clarifying that Kawasaki quest. So in the last echo I can't remember which echo, but it was a COVID echo. Someone asked about steroids and Kawasaki. I just gave them my best hunch was, if they're indicated, anytime you have a disease that steroids are life-saving, if they have COVID, tough luck, you won't let them die of that disease. And COVID, they're controversial, but you give us some good, more objective data that we should use them if need be.
Yeah, of the three case series, there were 10 children in Italy, 8, I believe, in the London series, and 15 in New York City. There was only one death out of those, what would that be, 25, 33 cases. One child in London died of a stroke, basically. So the Italian experience, they were really advocating the use of steroids in these cases, and the other 2 also advocated steroids and had not had bad experience with it. So I think your hunch was absolutely correct.
There's a question in the chat. As tribes develop capacity and roll out mandatory COVID-19 testing for HCWs and essential business employees 2 weeks regardless of symptoms in the Northwest. Curious if there are any lessons learned from tribes or other organizations.
I mean, we have not rolled this out. Actually, we're about to roll it next week. And unfortunately, well, we don't have enough testing capacity to guarantee Q2 week testing for health employees. And also in Cherokee Nation, it's not only health employees, but it's also the other Cherokee Nation employees that are not health. So health is like 2,500. Then you have to add like two or 3,000 more. It's like 5,000 people. And if you're testing 5,000 every 2 weeks, you need a really big, robust test capacity. But what we decided to do is, since now Oklahoma's opening and many of the healthcare workers are going to start coming back to the facilities, is let's test everybody at least once. And it'll give you limited information, but at least we'll have some information of what is actually the prevalence of asymptomatic carriers in our community, at least in our workforce community. And also give us experience of how doable and feasible was it to deploy, testing so many people in a short period of time. The antigen, okay, the first formal antigen lecture here is the one from today. I thought it was great. I think it's something to consider, but we really need to think it carefully on the cost and how many, if we're going to be duplicating our costs, it's not going to be feasible, but I think we need to calculate all that. And I need to jump out. I'm sorry. Thank you very much. It was a great meeting, and we'll see you next Friday. I'll see you next Friday.
There is a survey in the chat. If you will click on that link and fill out and give us your feedback, that'd be great. It helps us develop content for these. Do we have any other questions? If not, we can go ahead and end. Have a great day. Don't forget to fill out your survey. Have a great Friday. Thank you all.
Bye, everyone.